I think you do. Anyway, if you don't, let me know. So I will talk to you a little about self-harm in young people and COVID-19. I'll give you a bit of a. So before I start, I just wanted to say that I really haven't got a lot of interest to declare. I wrote a couple of books on self-harm, and I do get royalties from them. But also I have written a book with my daughter on West Ukraine, which is where I'm from, which has nothing to do with self-harm, but just a matter of pride for me. So I will tell you a little bit about identifying sort of general trends in self-harm and suicide, and then thinking about some of the risk factors for self-harm, thinking about what actually happened to hospital admissions for self-harm in emergency departments in young people during COVID, and then think about what the implications of this might be. So this is the world before COVID. You can see on this map that countries with sort of dark blue, dark green sort of color are countries where suicide rates were going down, and countries that are sort of yellowish to dark brown are countries with suicide going up. You can see that Egypt, even though the absolute suicide rate seems low at 5.5%, 5.5 cases per 100,000 per year, was on the trajectory of going up before COVID. We really don't have good evidence what actually happened during COVID. I would say, however, that there is no reason to believe that the suicide rate has increased very substantially. If you look at different areas of the world, then you can see that, generally speaking, suicide rate goes up with age. So people who are oldest will have the highest suicide rate. There are two exceptions to this. One is females in Southeast Asia, where you have this bimodal distribution of suicide with very young females having a higher rate than old females. And the other exception is Central Europe, especially in males, where you can see a very substantial increase in suicide in younger age groups and middle-aged men in particular. In Europe, there is a very clear difference between northern and eastern countries and southern and western countries, where the highest suicide rate in young people in this case is actually in the Baltic states. Lithuania often comes top of that list. In the UK, we have seen a fairly flat curve of suicides in both males and females. Males, of course, male suicide rate is significantly higher than female. You can see that the top curve are males, and the bottom one is females. But really no major differences except for the last couple of years before COVID, when actually there was a trend towards an increase in suicide rate. In the youngest young people, 10 to 18-year-olds, you can see that even though the absolute numbers were actually quite low, then suicide still remains the second leading cause of death in this age group. Only traffic accidents in general, are more common than suicide. In females, you can see that over the last 30 to 40 years, things have been somewhat more promising, especially for the older age groups. However, from about late 90s, and there was a flat line with really no major differences. You can, however, see that the bottom curve, which is the rate of suicide in the youngest females, that, in fact, had a tendency towards increase in the last few years. And in fact, the last year where we have good data, which is 2019, that year saw the highest rate of suicide in the youngest females in the UK ever recorded. So there is something really worrying happening with our young females. In males, we really have not seen the same trend in suicide rate. You can see that perhaps the only good piece of news is that the oldest males, it's the grey line here, So they tended to have a reduction in suicide rate, and now it's the middle-aged males that have the highest risk of suicide, not the oldest males. Mondays typically are the day of the week with the highest suicide rate, and in countries where the working week starts on a Sunday, then it's the Sunday with the highest rate of suicide typically. There are some specific age groups, but also there are some specific diagnostic groups that need to be considered when talking about suicide. For example, Bruce was talking a minute ago about young people with BDD. We also need to remember about people with ASD, autism, spectrum disorders. We now know that the overall risk of suicide in that group is about 7.5 times greater than in people without ASD. And in those people with ASD who do not have intellectual disability, that risk is even higher, but it's nearly 10 times. When it comes to methods of suicide, then traditionally in the UK and in many other Western countries, hanging was the top cause of death in males and poisoning in females. Around 2010, there was a crossover, and now in the UK and many other Western countries, it's hanging that is the top method of suicide in both males and females. The exception to this is the USA, where firearms are the top cause of death, or top method of suicide. These are young males in the UK. You can see that there was a tendency towards a decrease in suicide from about 1998, but that has reversed now, and we do not see the same trend towards a reduction. In females, as I mentioned before, in young females, we now have the highest rate of suicide ever recorded, and the early indications from 2020 seem to show that that tendency continues. Moving on to self-harm. Self-harm, of course, is by far much more common than suicide, fortunately, in young people. The sensible estimates of prevalence of self-harm would be somewhere between 15 and 20%. Lifetime before the young person hits 18th birthday. This is a slightly older study which shows prevalence which is significantly lower than what is currently happening. But you can see the interesting thing about this study is that it does show very dramatic differences in the prevalence of self-harm in different countries. It's a very interesting finding which we could discuss in Q&A if people are curious about that. Now, in terms of, again, I wanted to go back to young people with ASD. Prevalence of self-harm in that group is about 50%. I think Bruce was saying that it's probably about similar to what he sees in BDD. However, the phenomenology of that is a little bit different in kids with ASD. Often abnormal sensory processing seems to play an important role, as well as insistence on sameness and cognitive ability and social functioning. When we look at self-harm from the primary care point of view, then again, you can see that girls are much more likely to self-harm than boys. And again, like in suicide, you can see that in the youngest age group, there is a tendency towards an increase in the number of young people who come to primary care with self-harm in the last few years. And then globally, so everything I was talking about so far really is about the Western world, whereas this is globally, and you can see that globally still suicide, i.e. death via self-harm, is still very close to the top of causes of death in young people, 15 to 19-year-olds. In girls, only maternal conditions are more common, and in boys, it's the road injuries and homicide. Is there anything we could do about self-harm in young people? Up until 2015, the answer was probably no. we really did not have much evidence that any psychological therapies were particularly effective. In 2015, things have changed a little bit, and you can see that that was the first year when my group started saying that actually we are not wasting our time, and overall effect here is in favor of psychological therapies. So this psychological therapy here, Malin 2014, is DBT, which stands for Dialectical Behavior Therapy. At that point, in 2015, it was the only study, very large effect size, as you can see. However, now there are 3 studies of DBT, 3 RCTs. All of them are positive, which really makes DBT by far the therapy with the greatest evidence base. If you then also include adult studies, it really is the therapy to choose. Now, in collaboration with my Austrian friends and colleagues, we have published an updated meta-analysis last year of psychological therapies. Again, the overall conclusion is that we probably do more good than harm with psychological therapies. DBT again showed the greatest promise. One other thing just to mention is that the previous slide we're talking about self-harm, i.e. the actual behavior. When you think about thinking about self-harm and thinking about suicide, then DBT also stands out as an effective therapy. But there is also some evidence of family-centered therapies that also seem to have an effect on suicidal thinking. I will not spend too long on this slide. You will be familiar with most of these risk factors for self-harm. I just wanted perhaps to mention a couple here, which certainly our junior doctors do not ask about very often. One of those is non-heterosexual sexual orientation. The other one is the history of self-harm in the family. It's something that is one of the strongest predictors, but rarely asked about. Now, what about moving from thinking about self-harm to actually self-harm? For example, in this case, thinking about suicide and then making a suicide attempt. These are the strongest known predictors of the transition from thinking to actually acting. You can see here, again, from a relatively new risk factors, is body dissatisfaction, and Bruce did talk a lot about this, and it's really one of the very strong risk factors, which is really worth asking about. And then thinking about the actual completed suicide, again, just wanted to focus your attention on a couple of things here, which perhaps our junior doctors are not asking enough about. One of them is the family history of suicidal behavior, which is a very strong predictor of actual suicide. The other one is, adverse childhood experiences. It's, again, something that we have known for a very long time, that these so-called ACEs are highly predictive of actual suicide. But when we look at our juniors' records, they're not often asking about that. So what happens to young people who come to emergency departments with self-harm? When I started training, and in fact Bruce was one of my consultants when I was a trainee child psychiatrist many, many years ago now. At that time, the risk of repetition of self-harm, i.e. coming back to emergency department with self-harm, was about 10%. At the moment, it's probably close to about a third, so 1 in 3 kids will come back to emergency departments, in the UK at least. 1% of them will die over about a 10-year period, and about half of this 1% will be death by suicide. The other half will be mainly traffic accidents, some of which may well be, in fact, be suicides. The thing here to focus your attention is that as far as A&E or emergency department presentations with self-harm, that is the violent method of attempted suicide, such as attempted hanging or jumping from heights, which carry a significantly higher risk of actual death by suicide in 10 years, about 8 times greater risk than a non-violent method such as self-poisoning. A couple of years ago, I was editing a special issue of JCPP, which is the leading journal in our field, specifically on self-harm and suicide in kids. And I was editing this paper, which I thought was remarkably well conducted. And we have known for a long time that one of the important risk factors for self-harm and suicide in kids is social isolation, i.e. not being connected to your friends and family and other people. But what it showed, that paper, is that kids with attempted suicide are red dots. That not only are they isolated from other kids, but they also seem to co-segregate together. So their social connections tend to be with other young people who think about suicide or attempt suicide. Something that is really important to account when you think about managing self-harm at schools. We are nowhere near where we should be with our ability to predict suicide, especially suicide, but even the repetition of self-harm in kids. There are some really interesting new ideas. If you have the time to check out this website, it's the Implicit Association Task, which my colleague Matthew Nock developed at Harvard. Do have a look. It's really interesting stuff, which measures your latency when associating issues to do with me, I, myself, and life on one hand, or death on the other hand. Very interesting stuff. So, moving on to the current pandemic, we've got a number of risk factors for self-harm and suicide in kids, which have been significantly more common since the pandemic started. Anxiety is one of them. Isolation is another. Access to mental health services have been problematic. In fact, we have seen about a 30% increase in the number of referrals to mental health services in 2019-2020, which is unprecedented increase in the demand. Domestic violence is something that had been repeatedly talked about as a possible consequence of spending a lot more time indoors, increased alcohol consumption, increased exposure to social media, and of course, for some relatively small but minority of kids, it's the increased bereavements due to COVID. So we were curious about this, and we wanted to see what actual impact COVID had on the presentation of young people to emergency departments in different countries. So what we have done is we looked at over 2,000 presentations in 10 countries. We compared March and April 2019 to March and April 2020. We had all of these countries who contributed to the data gathering. And what we have found was that compared to pre-COVID March and April 2019, March and April 2020, which was the peak of the first wave of COVID in most countries, we actually saw a very substantial decrease in the number of psychiatric presentations to A&E departments. However, within that substantial decrease of the total number of psychiatric presentations, the proportion of kids with self-harm actually increased. That was really shown in most countries. A few small exceptions. For example, we did not see this very clear difference in Turin and a few other countries, but in most countries we actually saw this very stark decrease in the number of kids coming to emergency departments with psychiatric emergencies. Some other interesting findings was that young people who had previous history of hospital presentations with self-harm were much less affected by this. So they were much more likely to come back to emergency departments as opposed to kids who have never been to emergency departments with self-harm. But we did not find any differences in this behavior when we looked at kids with or without previous self-harm in the community. We also, contrary to our hypothesis, we did not find a substantial difference in the severity of self-harm. So we looked at the proportion of kids with severe self-harm that required intensive care unit or perhaps a long admission to a hospital. And in some places like Edinburgh, it was a clear difference there, but in many places it wasn't. And overall around the world, we could not find enough evidence to say that the proportion of kids with severe self-harm actually increased. We did find a substantial increase of young people with emotional disorders coming to A&E with self-harm. That was in accordance with the hypothesis. We all expected to see more young people with emotional disorders, especially anxiety disorders, and it was the case. We also found that young people were less likely to be admitted overnight during COVID than before COVID. Perhaps understandably, we were less keen to admit young people in hospitals with high risk of COVID. And we also found a number of important negative results. One of them was that if you looked at overall young people from deprived areas, they were no less likely to seek help in A&E than kids from affluent areas, except for a very small proportion of young people who are at the bottom decile, i.e. bottom 10% of deprived kids. Those kids were, in fact, much less likely to come to A&E after an overdose than kids from more affluent areas. So it's not just deprivation overall, it's the greatest deprivation that you can find, and that demographic are the kids that actually will be much less likely to come to A&E when they need it. We did not find any differences in ethnic minorities. That was important. If you adjust for socioeconomic status, that is. We also did not find any differences in the chances of young people being offered follow-up appointments and attending these appointments, also importantly. Admittedly, we took into account those face-to-face and phone follow-ups and also remote follow-ups. We were then wondering whether, in fact, the reason why we saw such a dramatic decrease was because we were admitting more kids to inpatient psychiatric hospitals. And that wasn't the case. So when we looked at the number of admissions in March and April 2019-2020, in fact, that's the bottom line here. You can see that it was actually going down. And in fact, in April 2020, the number of admissions overall in England was 249, which was the lowest number of admissions in many decades. So the implications were, at that point, that really we should not invest a lot of money in hospital services, because the number of kids during that first wave was significantly lower than before COVID. And the investment should have been, and actually was, in community services, so in outreach services, services that will actually reach out to the children who may be suffering at home, but are not very likely to actually come and seek emergency help in hospitals. I must say that we have now nearly finished data collection on about 26 countries. We have nearly 7,000 presentations now, and we are comparing 2021 to 2020 and 2019. We haven't published the data yet, but it seems to us that the number of young people coming to emergency departments this year is significantly higher than the number of kids coming in 2020, and quite possibly even 2019. We need to actually check that out. We also seem to be finding very unusual presentations, not just anxiety, but a lot of young people with eating disorders and tics, which is something I could not have really predicted. And so really just to summarize, COVID had a massive impact on health-seeking behavior of kids with self-harm. They were much less likely to actually come during the first wave of the disorder, of the pandemic. that seems to have stopped now, and the number of kids coming to emergency departments is actually increasing. And we need to be thinking about the balanced development of both inpatient emergency services and community services to reach out to those kids who, for whatever reason, feel less empowered to actually seek help.